Do we have too many mics in this group? We should have thought about the names.
If you were born in the 70s, you're a boy.
Is that when Mike Dean was born?
Yeah, I mean, Mike Dean and I were in 6th grade together. Okay. So I'm Mike Spader from UVA, for those of you who haven't met yet or don't know already. I was in the education and simulation group. I think all of us were heavily influenced by Vinay's presentation this morning, which was, I think, equal parts inspiring and also terrifying, sort of in the sort of Gattaca-like world of the PICU he described, which I felt like Ethan Hawke, you know, like imposter syndrome, but being able to be detected. We hit on a lot of really nice themes, thinking about sort of that intersection of sort of data technology, education, and simulation as sort of being part and parcel of that, and really viewed learners, or we took it upon ourselves to really consider learners as really all of us, whether you're a trainee, whatever your field is, if it's nursing, if you're a physician, if you're an APP, an RT, and then also I am at the University of Virginia, and while Thomas Jefferson is a very complicated figure in our nation's history, he did believe in the concept of lifelong learning, and you're never a freshman or sophomore, you're a first year, second year. So this idea, thank you, that's for Steve Schein, this idea that we're all continually trying to learn and better ourselves. And so some of the initial sort of concepts that we identified were data literacy. How do we all interact with data and perceive data? I think all of us have been on rounds, and it's the first day of the rotation, and literally the second year resident just vomits a whole set of data onto you and not really sort of understanding what it means and how it sort of fits together. So we talked about sort of data literacy. We talked about autonomy. How do we continue to allow for sort of autonomy for the learners in terms of how they're sort of interacting with this, but how do we also sort of protect them? You know, I talked about psychological safety. I think we talked about sort of safety in general for them, and that relates to things like privacy. What were the ethical? So justice, privacy, confidentiality, autonomy. Wonderful. Thank you to our Professor Mabea. We also talked a lot about the idea of using technology, data in an education space to sort of establish competencies and practice variation, and how specific practices adhere to national standards. And then we also talked a lot about the use of technology and sort of novel types of technology and almost sort of precision education as it relates to a lot of the things that Vi and I sort of talked a lot about this morning in both the simulation space and outside the simulation space. So our prototype is the I2E2. Sorry, thank you. I2E2, individualized, immersive, experiential education platform. Yes, TM. we've already submitted a patent. So I'll describe it, and then we can sort of talk. So we visualized sort of an individualized application for the learner that would sort of encompass all of these 4 major themes that we discussed. And so I'll sort of walk you through it. And so the idea here is you have your learner, and as I mentioned, we're really talking about everyone. And that learner is interacting with patients or interacting with other providers. So this isn't necessarily just based on, taking care of patients. How do I interact with colleagues? How do I interact with the nursing staff? And then we also have EHR, and I would add, since we're talking about data sources, maybe we're also feeding in things like waveform data or Press-Ganey data, things like that. And so there's an interaction at this level, and then the learner has also another data source would be 360 evaluations, if there are trainee evaluations from their program that sort of informs it. And then you have this individualized learning platform that takes into account not just the level of the learner, but the type of learner. Are they a visual learner? Are they an auditory learner? Where are they in their training? What is their sort of field of specialty? And then considering a specific exposure. It could be a patient encounter. We kept coming back to the idea of bronchiolitis and how many of our trainees didn't experience bronchiolitis in the previous years, and use the example of your resident or fellow who keeps wanting to give albuterol to this intubated bronchiolitic as sort of an example. And so we have here the measure of the exposure, receiving data from the EHR, and then in allowing for several different layers here. So we have sort of the competency. How did that learner perform in that exposure as it relates to how they dealt with the patient, their medical decision making, and then it individualizes in a potentially immersive environment, either a sort of VR or simulated educational simulation where they could recap the specific patient encounter, if that's the case. If they're at the same time, we'd be tracking, is this the first time they've ever put a patient on ECMO? Have they never seen a patient go on ECMO? How do we then also use this to educate them for something that they're not as familiar with or is not as skilled with? And then based on what the way they best learn, do we do it in a simulation environment? Do we provide them links to printed text or video if they're a visual learner? And then I think we all sort of agreed that we are seeing more and more learners that are using podcasts as part of their learning. This would also allow them sort of exposure to just-in-time checklists. And it's also giving them the opportunity to sort of replay that episode, learn what they did right, learn what they did wrong, provide them feedback. And even we discussed that sort of like when you're going on to TurboTax and they're like, can I help you with this? You're putting your kids' 529 information in and you don't know exactly what you're doing, your 1099-Q. I'm doing my own taxes right now. And to be able to talk to that expert, so having subject matter experts at the level, at the institution level, and then all within the framework of psychological safety. So providing them, this is all would be sort of anonymized, but also providing them that safety if it was a traumatic event, for the opportunity for debriefing. And feeding that back to someone to check in on them. And so I guess I'd ask my other members of our group, anything I'm missing on the I2E2 platform, TM?
We talked too about if we have the professionalism evals and the 360s and whatnot, and there's detected issues with things like bias or not ideal communication skills, that could be fit into this tool and allow for some of the simulations to be, for example, if it's a virtual environment, maybe the virtual provider that's helping you go through a simulation is a female nurse or an African American physician, and try to work through whether that is something that you can train the learner to have to work through their biases or communication skills and things like that. And we talk about the simulation being generative AI VR type thing, so like deep fakes, so that you can actually get real data from the EHR, but then have like some visual patient that you see in front of you that you can interact with.
Serene.
I guess the question I have is, with the number of providers that touch the patient, touch the electronic health record, you have one resident will be presenting their plan for the patient, another resident will be putting in the orders, the attending will be deciding what the actual solution is. The RT might give the medication on time, and so on and so forth. How do you distinguish if a deficiency is found or if there's an area for improvement? How do we identify who needs to be targeted with that situation? Is it everybody on the team? Is it?
Yeah, that was a point of discussion, and so yeah, it would be the entire team. And I think so the example is you're on call at night, you're the attending, you've gone to sleep, your patient's lactate is rising. It's a post-op cardiac patient. Barry's asleep, and and Barry's fellow is nervous, and they're trying a couple things. The lactate continues to rise, right? So it's time-based. It's like who was on at that time. But then the fellow then recognizes that they've reached their limit. They call Barry, and then you see a downtrending in the lactate because Barry comes to the rescue. So it basically, in that case, you're dealing with multiple people in that setting, dealing with that. This is just a prototype.
No, I'm not. My question wasn't even really about the specific prototype, but I think that
Yes.
that's the hard part with connecting to the electronic health record is identifying who is responsible for any action. I guess because of how many people are involved with every decision that's made nowadays.
I think Tim and
one of the things we talked about is if this is linked to the EHR, as an attending in Barry's case, right? He can go back and say how many, 6-week-olds post-op have I taken care of, and was this incident different than the other 8 in the last 6 weeks or whatever, and so you get that internal control, and maybe all of them the lactate's going up, and then he can step back and say, or you could prompt the learning platform to say, ooh, do you know about supervision and autonomy? And maybe you're giving your fellow a little too much leeway here, and kind of go through that process. So it shifts the learning from, how do you take care of a post-op kid when you're in bed to how do you give instruct your fellow into when to call you. So it wrapping all that in and all that has to be connected to the EHR, right? So.
No, I think. Yep. I think the key is one of the beauty of this proposed the app is the learner-centered approach. That means if I'm the resident or fellow, I have incentive to claim that the patient care I provided, so that by the second year, the end of second year or the third year, now I know I took care of X number of cardiac patient who is failing on the first night, but I saved them. And by the way, some of them I called Barry, right? So there's an incentive for that. Then, so I have platform. Then I have X number of clinical encounter cases, and I supplemented because I was deficient in certain things that interactions, the communication with my team members. That I do same, right? So I have all the portfolios built within the app. So I have incentive to claim that. So I think that's one of the beauties. Other thing is that the psychological safety as well as some legal protection, because the data is within my app, so that it's not like hospital holding the training record. So that actually protect me from getting so many remediations, so to speak.
So I love a lot of elements of this. I'm not sure if your example holds water necessarily, only because we're all going to teach in that instance, right? Our fellow calls us.
I literally made it up on the spot.
No.
Fine.
But I think that's not where this really has its true beauty. So I think where this can really be impactful is, okay, we have 20 minutes. And I want to teach on something. This can help me identify the best topic to teach, the one that has the highest probability of being impactful. So that it's not necessarily to find the things that that we already know, like, hey, this is a teaching opportunity, but when we have time to teach, this can help us figure out sort of what the right thing is. And that way, you can also make it to be very clear that it's not a punitive thing. Like, I'm not teaching you this fact because you screwed up or anything. I'm teaching you this fact because the algorithm says the thing that's most likely going to be beneficial to the team that's here in front of me based on your guys' experience and based on what we see in this unit and the time of year and all that kind of jazz, that the most likely thing to be impactful is this. So let's teach about CRT today, because it turns out only one of you guys have ever seen a patient on CRT.
And if you can couple that with, like, there's a kid at high risk of needing CRT, then
Yeah.
adjusting time medication before it's needed.
And I actually like that a lot, because I think one of the things that we were trying to reconcile was this concept of this is very much learner motivated, learner driven. And in your example, it's a little bit more, it's initiated by the educator in that case to start that process. I think we all worried. Mela brought up the point that people aren't reading as much as we remember doing, back in the day. And this idea of, I think, for all the millennials in the room, close your ears. But you guys learn differently than maybe some of the Gen Xers and Boomers in the room did, and are a little bit more engaged with some of these other sort of forms of education. Whether it's TikTok or podcasts or whatever it is. Yeah, that came up. It came up.
That's how very.
It's how very.
Sounds good.
Thank you, Master. So I want to shift with a question actually for the group a little bit, and I like your approach and how you're thinking this through. And you mentioned, or the group is thinking, you mentioned about data literacy, you mentioned about some concepts like, confidentiality, EHR kinds of concepts, but we've been talking here a lot about technology and infrastructure and AI models and et cetera, et cetera. Did the group talk or, discussed a little bit about how do we teach the new generation some of these concepts? I bet most of you learn or by yourself or because you have a mentor that liked data and start working on that, or went to a program and did a master's degree. But how do we bring that into the practice? Because more and more we're going to say, oh, these genes are all connected. Do the physicians know what to do with them? The AI models, they are there. The prediction is there. Do we know how to interpret them as clinicians? And how we are going to use that? How do we incorporate that into maybe medical schools or residency or fellowship programs? Did you guys talk a little bit about that?
We did, and in full disclosure, we're stealing a little bit from Maya Dewan's research, who is working on developing a virtual learning lab, where you are sort of in this immersive environment where you are receiving data and have to interpret it in real time, and there's manipulation of that, and how do you respond to new pieces of data, and then how does that affect your decision making? So we would think that would be more experiential and part of this sort of immersive experience, that the second I in I2E2, sorry. But yeah, but to the bigger point, I don't know what the answer to your question is. I teach all our fellows in pediatrics. I do all their biostats and study design. I'm sure a lot of people are involved in these sort of things, and it's not good.
No, I understand. I do a lot of it. I know it's not good. I understand
it's like
you're
a
not
C-.
good part. I understand you're not good part. Some institutions have incorporated informatics into the medical school, right? And I worked many years in Wisconsin to incorporate informatics into medical school. Finally got there. Then I left Wisconsin, but that's another different story. But like OHSU has informatics throughout the curriculum, and some others do have. I think for us to be able to get the new generation of all of us, we need to start thinking more about that. And I know Maya's work is a great work, and I saw her work in part of what you said. But I think we need to also think about the other part, which is really how do we teach the concepts of, the concept of what is machine learning, what is AI, to write a model and what is important to interpret on them. It's just a side note on that.
Thanks. The idea of capturing trainees' experiences from the EHR is very cool, and there's been some work to look at to validate that against what trainees actually call their own experiences in the EHR. One of the challenges that we've had in doing that work is getting this to go multi-center. It's relatively simple to do, or simpler to do in your own site, and I wonder if there's an opportunity with a potential multi-center data collection site that we're talking about in the next day or so, to utilize some metadata attached to that would actually link to individual trainees, again, in a de-identified manner, but using, for example, elements that we're not capturing in the PDC, such as access time in the EHR from audit log data, or entering of orders, entering of notes, things like that, that would predict trainee matching to a patient. Did the trainee work with a particular patient? And then keep track of that data in a multi-center environment. And then you'll be able to track in all of these centers what the trainees are seeing, what diagnoses they're seeing, how many patients they're taking care of on a regular basis, things like that. Certainly, yeah.
Maybe I missed it, but where's VR and AR? And I mean, I don't know the numbers, but airplane pilots can't touch an airplane until they get into a simulator, and they keep going back to the simulators to keep retraining. And why? I mean, we're using it for for the patients to diminish pain and that whatnot. But what about teaching our trainees?
Yeah, I mean, I think that would definitely be part of the I2E2 platform. But you're right. I mean, I know exactly. We're workshopping it. I think Maya's virtual learning lab is using a VR platform, and I think there's more and more, at the medical school level, of using augmented or virtual reality to have these virtual patient encounters. And so, yes, I think that's definitely an integral part of what's going on. And they all have their Oculus, at home, and are
the one thing we talked about the AR VR piece is that it's really expensive and really time consuming to build these scenarios, and particularly if you want to build it so that it's adaptive learning, so that you get a simulation on specifically the intubated broncholytic who's wheezing and non-responsive to beta agonists, and you want to teach the learner how to go through that process and that decision making, like that. Those are hours and hours of development to build that scenario, unless you leverage these generative AI models and say, build me a clinical scenario, virtual reality scenario where a patient is wheezing and is not responding to beta agonists, and then you can have a generated virtual reality scenario. But I don't know that we're there on that level yet, but I think that's the biggest limitation. And only places like Cincinnati, where they have more money than they know what to do with, can spend the money on developers to do it. But it's true. It's true. Okay, so I think we're out of time. Yeah, I think we need to transition to the next group so that we finish on time. So quality improvement, ICU liberation.